Good evening, my name is Blahin Brady and I'm a specialist physiotherapist here in Sports Surgery Clinic. And this evening we're talking about enhanced recovery and this model of patient care that we use here in Sports Surgery Clinic. This evening discussing this with us is Mr. Gavin McHugh, consultant orthopaedic surgeon specialising in hip and knee surgery here in Sports Surgery Clinic, alongside Mr. Mihai Varaniu, consultant orthopaedic surgeon, again specialising in hips and knees here in Sports Surgery Clinic. Thanks, Gavin and Mihai, for taking the time this evening to speak with us. So I guess just to start off, Mihai, it probably is a good idea to introduce the concept of enhanced recovery and really what it is and what it means for the patient.
Yeah, thank you, Blahin. Enhanced recovery has been going on and initially started in general surgery, in colorectal surgery. And Professor Kellett in Copenhagen in 1990s, his hypothesis was that surgical stress along with metabolic and endocrine derangement, along with prolonged immobilization, lead to what he called organ dysfunction. And really what that is if you look at all the organs and the respiratory system and the cardiovascular system and the GI tract, they all being affected by this stress, by this derangement, which is metabolic and endocrine, and by the prolonged immobilization. And patient gets nausea, get vomiting, get ileus, get fatigue, get cognitive derangement, and their muscles weaken up, and they become sick. Mm-hmm. So along with Professor Kellett in Copenhagen was this orthopedic surgeon, Henrik Husted. We, both myself and Gavin, had a chance to meet him at various meetings in Ireland when he was invited as a speaker. And in fact, would have been a good few years ago, 10 years ago, if not, he introduced the concept to me, at least, anyway. Dr. Husted did a lot of work and his team in Copenhagen did a lot of work in enhanced recovery or rapid recovery, as other people would call it. And eventually, it's the concept of not treating people as sick, but treating people as well, so patients are well and they're not sick.
Yeah.
That's what it essentially is in a nutshell.
Brilliant. And Gavin, I guess over the last couple of years, we've adopted this approach here in Santry. And is it something that's very much surgeon driven? Are there more people involved? Is it multidisciplinary, or how does it work?
I suppose it's not about necessarily just adopting this thing. I think I would look at it all as a bit of an evolution. And I think even if you look at us all over the last 10 to 20 years, we've very gradually, slowly eaten away at the length of time that people take in hospital in order to sort of complete their sort of hospital type of recovery process. And I just look at this as an extension of that, And I mean, if you go back 20 years ago, people spent 2 weeks in the hospital. If you go back 10 years, they spent a week. And if you go back, about 5 years ago, they spent 5 days. And now we're getting that down all the time to sort of 1, 2, 3 days. Obviously, lots of the world are routinely, the enhanced recovery is almost looked at as day case type procedures, but it doesn't necessarily involve that. A lot of the patients we're dealing with have a lot more comorbidities, and it's a huge achievement getting them out even sort of day 1, day 2, day 3, compared to a number of years ago.
And I guess we're, probably the main patients that I've definitely seen the change with are replacement patients, our partial knees, our total knees, our uni knees. They really I can see the impact of that from a post-operative point of view. And is there, if we maybe start at the idea of, initially adopting this with the patient, does it start from the time you see the patient for their initial appointment, or how do we start this enhanced process pre-operatively, say?
Absolutely. Well, I think, the first seed has to be like planted in the consultation. But again, the whole key to the success with it is with the team-based approach. Absolutely, everyone has to be sort of, like, to avoid the cliche of singing from the same hymn sheet, but it's so true is that you cannot have one little break in the chain where, you know, someone expresses doubt along the way. Everyone has to sort of be, and that's right in the initial consultation, to maybe seeing yourself or a different physio preoperatively, to being seen in the pre-assessment clinic, to being seen on admission, to being seen by the nurses, by the anaesthetist. Everyone has to be sort of involved in the whole process, and encouraging people that this is for their benefit. It's not a sort of, you know, a money saving issue. I mean myself and me or yourself, we've nothing to gain from getting patients out earlier, and potentially we've a lot to lose, because if anything goes wrong, then it's seen as egg in our face type of thing. But it's not. It's realizing, no, this is actually great for them. This actually gets them to where they need to be sooner, and not just home in terms of the recovery process. You know.
Brilliant. And I guess with regards educating patients and informing them on it, Mihai, I know over the last couple of years you've adopted a few different methods to inform patients of the ins and outs of the surgical process. Could you elaborate a little bit on that?
Yeah, I guess just to add to what Gav was saying, I think sometimes patients are already primed by their friends who have been going through some, as they say, well, look, this is the attitude that you meet when you go there. They want you up, they want you walking straight away. And yes, I guess we have all sorts of brochures that we give them. I think that first of all, along with selection patients for surgery is also an important, we both spend a good bit of time with the patients, just establishing the right expectations, you know, when you do a knee replacement for someone who's 50 versus someone who's 70. And I think that's where some of our focus is during the surgical consultation. And then we do give them a book outlining their journey before, during, and after hip and knee replacement. And the book is quite late term and it's quite simple. And it's almost like a checklist. What do you bring to the hospital? When do you organize a discharge? Who's going to pick you up? How are you going to get into the car? And one thing about this program, and as Gavin said, it's organic. It's not really a program. It's something that is very low tech and low cost and has so many aspects. In fact, I was preparing this talk, I made a little effort and sort of mental exercise trying to count the number of changes that we are doing different. And there are over 20 small little changes, you know, that I could sort of identify in the process compared to what we were doing when we were trained, for example, you know. But all has to get to the patient that they are well, you know, they're not sick. They're coming in well. And there's so many small little things that, for example, we would insist that patient walks into theater rather than being wheeled into theater. And that's a small aspect, but to him, it gives him the impression that he is well, introduces himself to the staff, tells himself which side is being operated on. And all these little things that they're built into the system and they're done routinely. And as Gavin said, everybody knows that they're being done. It's not haphazard, sort of. It's not happening by chance, so to speak. But to come back to the program, I think there are three aspects: reducing pain, blood preservation, and early mobilization in our field, in orthopedic surgery. And they're very interlinked because, you know, blood preservation and less bleeding leads to less pain and facilitate patients to get up early. So they're all very interlinked. So hopefully we'll have some time to spend between me and Gavin around those little aspects. Yeah,
brilliant. And I guess then, focusing on the fact that we're trying to reach out to GPs here, I find with some patients as they come into initial consultations and they've been booked in for their surgery, you know, it can be that initial, obviously, diagnosis that they're heading for surgery can be daunting, and then they get all this information, and I'm sure then sometimes they turn back to their GPs with more questions. Could we maybe start with regard that enhanced recovery process, and just like what you've said there with reducing maybe pain first of all, what tends to be the main components around that surgical journey, be that pre-surgery, intraoperatively and post-operatively, that you tend to do to help reduce pain? Gavin, maybe we'll start with you.
Oh, Grant, sorry. I was waiting for me to answer that. So yeah, but you hit the nail on the head there by even saying pre-operatively as well. All right, I think that's the key, is starting even before. So it's trying to prevent a lot of the pain rather than treating it when they get the pain. So it's potentially loading patients on the induction of their anesthesia with analgesia, and it's over the years we've been very opiate heavy in terms of our pain relief. And it's trying to stay away from a lot of the opiates as much as possible, as whilst they're good for the relief of pain, they're bad for the side effects. And I mean, we've all seen the patients, day 3 post-op, who are miserable because they're constipated, and it's from 1 or 2 doses of opiates. The pain is way no longer an issue; it's constipation. But so it's often dealing with the side effects of pain as well as the pain. So. A huge thing, obviously, that has been introduced, even in quite a number of years ago now, is we pretty much all use periarticular block in both hips and knees. And I think, as I say, I think everyone's using that nowadays with a mixture of local anesthetic, morphine, and adrenaline. So it, again, as Mihai says, helps potentially reduce the bleeding, but it also deals with a lot of the pain, and that will often keep people pain-free more or less for the first guts of 24 hours, 18 to 24 hours. But again, it's preempting that pain that can come on, and that sort of falling off the cliff edge when the local anesthetic wears off they need to be loaded up with analgesia prior to that. Again, it's other modalities, anti-inflammatories, if they can take them, even just simple paracetamol as well. But I think, I mean, as Mihai says, it all goes hand in hand, because by getting up a lot earlier, you actually prevent a lot of the pain from actually setting in. It's much harder moving a knee that hasn't been moved for a day and a half than one that's just an hour and a half after their operation.
Brilliant.
I think just to add to what Gav said, which obviously our practice it's quite similar. I think we both introduce short-acting spinal anesthetic, and that is a low dose of spinal anesthetic combined with some sedation, obviously for the patient not to be aware what's going on and the noise, but the patients aren't going asleep. And there is a lot of evidence, suggesting that neuraxial analgesia, such as the spinal anesthetic, it enhances, it reduces the morbidity post-operatively, including the nausea, the vomiting, and facilitates patients to get up. But not in our case. I think we're using a spinal anesthetic that has about 90 minutes, wears off in 90 minutes, and facilitates, again, up on the ward assessment of the sensitivity and the motor return, and then maybe mobilizing at 4-6 hours after the surgery, which is really important, again, with pain, because remember, with the local anesthetic, periarticularly, patients, they're numb at that time,
Yeah. I guess kind of just keeping on the line of the medication, post-operatively, I see both of your patients at between kind of 2 and 4 weeks post-surgery regarding the replacements, and it's always the main topic of conversation initially is always medication. Some tell me they've come off it from week 1, others coming saying that they've been looking for more from their GP, and in particular, I guess, with speaking to GPs here this evening, could you maybe just elaborate a little bit more on what your thoughts on where that patient should generally be? Say if we take our typical, maybe partial or total knee replacement, at that 2 to 3 week post-surgery, I know we're usually trying to wean them down off some of that stronger medication. Is there any advice you can give to GPs at that point when the patients are perhaps reaching out to them with that cry for help, or what you would generally recommend?
I guess just following on that, the post-operative analgesia, between choosing the implants, it is a big difference between doing a partial knee replacement and a full knee replacement in terms of surgical damage, operating time, bleeding, And even the fact that we have preserved 2/3 of the knee with a partial knee replacement, the proprioception, the movement, it's much better with a partial knee replacement. And as you obviously notice from seeing these patients, they don't have that much pain. And, you know, they keep telling us, I had no pain. Then we see them, and I often ask them, did you have pain when you got home? Because when they're in the hospital, the local anesthetic works, and often they're on paracetamol, 1 gram 4 times a day. With regards to full knee replacement, obviously there is more swelling, there is more bleeding. What I tend to do, from talking to patients, I realized in the first 3-4 weeks, some of them report pain at night, but most of them don't actually complain of pain at night. They complain of restlessness. So they feel they can't rest, they can't sleep properly. You know, obviously the knee is swollen and they have some discomfort. So I tend to give them a sleeping pill, a short-acting benzodiazepam, Stilnoct 5 milligrams for 7 to 10 days. And patients who are not taking routinely sleeping pills, I tell them to break it in half and trying to see if half of a pill will give them a good night's sleep, about 4 or 6 hours sleep. And that's pretty much it. I mean, I know patients with gastric ulcers, and we tend to give them PR, non-steroidal anti-inflammatories, paracetamol. But I think essential is to move the knee, to get the swelling down and to engage moving the knee.
I tend to find that phrase of you pay for at night what you've done during the day tends to really hit into play, in particular for any of our patients who are doing a little bit too much during the day. So I guess that kind of leads us into maybe just before we move to mobilization, but just any other little key concepts. You mentioned bleeding, to try and reduce too much bleeding during the during and after surgery. What tends to be the concepts that you follow to try and help reduce that? Gavin, or maybe Gavin, we'll go to you for that one.
Perfect. Yeah. Well, I think tranexamic acid has been the absolute game changer for us there in terms of bleeding. I think it really has completely changed a lot of hip and knee replacements, and it's probably been the single biggest change that has occurred in the last 20 years really within orthopedics, because it's gone from a situation where routinely people, well, not routinely, but 10 to 20% of patients used to get a blood transfusion after a hip or a knee replacement, and now it's almost 1%. I mean, if even that. I mean, I remember seeing the audit in the sports surgery clinic, and the annual the total number of units of blood that we use per year is about 12 now. In the total year, and of that, 6 or 8 of them could have been used on one patient that was a major revision case or something. So it's really quite impressive, the change that it has made. And I know Mihai has kind of very much pushed the idea of continuing the tranexamic acid post-operatively as well. And there was I think there was a study there even in the last month to show that continuing that for 24 hours reduces your blood loss another 10%. So again, I think that is key. Now, obviously, meticulous surgery comes into it as well. I think you've more use of diathermy, things like that, than we would have had years ago. But for me, it's tranexamic acid that has been the game changer.
Yeah, I would agree. I mean, it's very cheap as well. I mean, tranexamic acid, it's an old drug that's been used in obstetrics to control bleeding. And it really has very few side effects. So I was trying to understand how does it work? So it inhibits clot degradation. So the clot that tends to form, sometimes it degrades and the bleeding continues, but it protects the clot. So it doesn't promote clotting. So therefore, we're not really worried about promoting PE or DVTs with using tranexamic acid. And yeah, you're right. I mean, there was a colleague of ours in Northern Ireland who published that study. I was just reading, and in fact, I was discussing it with my anesthetist only last week, because for knee replacements, it makes sense to give them orally 3-4 doses for the following day. And what I also do, a part of giving it intravenously at the release of the tourniquet, just before the blood goes into the wound, I also mix it with the local anesthetic, 2 grams into the wound, and that sort of acts topically. So there's a lot of research that it really acts any way you put it in, IV, topically, or orally. So not that much for the hips, but for the knees, for sure. And I think you, Gav, you see the same, that we go around, and I clearly remember about 4 or 5 years ago when we weren't using that tranexamic acid that much. The total knee replacement were very swollen, bruised on the lateral aspect when a lot of work is being done. But now there's not much bleeding. It's not much swelling. And that surely has to do with tranexamic acid.
Brilliant. I guess moving on from that then too, we've touched on a couple of times, we've mentioned early mobilization and the importance of that. I think that's one of the main things pre-operatively that patients get a bit worried about. They kind of are a bit shocked at the thought that they're going to be moving so soon. And I know, Mihai, you use that idea of, you're not sick, we need to get you up and going, up and moving, which is brilliant and kind of holds back with the patients. But can you elaborate a little bit more on the importance of that? I think from my point of view, psychologically as well as physiologically, it's so important because the patients kind of start to take ownership of their own recovery at that point. But could you maybe just elaborate, Gavin, on how early you do get them up and going and the importance of it?
Yeah, absolutely. I mean, it really depends, I suppose, on the spinal wearing off, because obviously you need to have them be able to get up safely more than anything else. So that can be variable. It can be early as sort of 1 to 2 hours after surgery. Sometimes it's more, 4 to 6 hours. A lot of it's related to the timing of the surgery as well, unfortunately, in that if someone gets their surgery in the evening time, then it's obviously much harder to safely sort of mobilize them sort of towards 10 or 11 o'clock at night time, but I always say to people, I mean, if everyone could get sort of the first 3 or 4 slots on the operating day, the list, it would be fantastic, because then they're up and you really see the difference. They behave the following day, they're like a day 2 rather than a day 1, so I mean, it's little things. It's even getting them moving in the bed and dispelling sort of the myths that that it's not okay, that people have to lie still in the bed is not. You'll still see plenty of hips that are afraid to move within the in the bed, that they can move, that it's fine, and that they're safe to get up, But in fairness, the team is absolutely super now in terms of getting everyone going. But once again, it's not just say the physiotherapist, it's the nurses, it's the healthcare systems, it's everyone that's there going, come on, time to get you up, because they're all realizing that it's for their own good,
Yeah. And again, then that probably leads into Mihai, those initial couple of weeks after surgery, the importance of those early mobilizations at home. How much kind of importance do you put on that? Do you think it's a key element to the recovery initially, say both knees and hips? I know different precautions involved with the hip replacements, but say those early exercises that the physios showed them in those couple of days, do you think that's a big component of the enhanced recovery?
I think it's important, and as Gav said, it's not only the physiotherapists who show them, but in fact the exercises are very simple. It's 3 exercises that they have to do. They have to straight leg raise to activate their quads, they have to bend the knee, and they have to stand on the knee to weight bear, and all this promotes muscle engagement. But one thing about the getting the patients up is that often, remember, patients, particularly if they're done in the evening time, they come in, they lie in bed, they're waiting anxiously for surgery, they read the book, but they're still doing in bed because they're in the hospital. They come in, they get the surgery, they lie back on an operating table, they have the recovery, and then they go to the ward. And if we get them up too early, for example, they have what the phenomenon called orthostatic hypotension. In other words, if you lie back, if me and you lie, like if I lie back for 24 hours, if you get up, you get dizzy. Yeah. And that is pure thermodynamics. The blood rushes down into the body and you get orthostatic hypotension. So what happens, they have a vasovagal and everybody gets scared and it gets put back into bed, and then have a night and then sometimes that happens in the morning, and then they get put back into bed. So before you know it, patients could be 23 hours in bed. And if someone after surgery would ask me when can they fly to Australia, we tell them about 6 weeks, because we don't want to let them 13 hours sit in a chair in one position. So that's the reason that the long flights promote clotting and DVTs. So the message that we have is trying to get them up, and then after, if they have such orthostatic hypotension event, try again, and they will actually get up. And if you get them up the evening of surgery, the next day they will feel so much better, and they could start fresh with a new physio session. They wouldn't have this orthostatic hypotension event, and the progression, it's incredible, really.
Super. I guess it might just be, I know you've both talked about and encourage patients, knees in particular, to use foot pedals, which there's been a lot of new research on in the last couple of years, on really the importance of them and how useful they are, even in comparison to physio or in conjunction with physio. How early, Gavin, do you allow your knee replacements to use pedals, or do you advise them to use them?
Again, I actually ditched that one to Mihai, because I know he's been much more of an advocate for the pedals than I've been, like, you know, so it wouldn't be fair.
Yeah, no, I mean, I just came across a friend of mine who is a surgeon in Surfers Paradise, Chris Vertulo, who himself and his team published a study where, and in one of the orthopedic journals in Britain, where they 60 patients, they had a set of floor pedals, which essentially is a simple set of pedals when you sit in a chair and you can cycle. And the other 60 patients randomized to a 10 exercise-based physiotherapy program, supervised by the physiotherapist. And they did follow up at day 2, week 2, and up to 6 months, I think. And at 6 months, there was no difference, but all the other timelines, they showed a difference. The guys who are doing self-directed cycling using floor pedals, they did better in terms of visual analog score, in terms of range of motion. And eventually it all got the same at 6 months. But it is indicative of what happens. And to me, it makes perfect sense. So if patients coming from theater has its dinner sitting with a set of floor pedals, it just has to do a few minutes, and just talking to the patients themselves, they tell you that it feels much better, actually. It just loosens up the tissues. You probably know from talking to them, Blóithín, about it.
Absolutely. It's even, you know, even today, a couple of patients, it's one of their main go-tos post-surgery, in particular the knees, just to get it mobilizing. Generally, a lot of them refer to it as their WD-40 to try get the knee mobilized and oiled up to get moving. So I've certainly found it's really helped them, and just give them that little bit of confidence when, and in particular, if people aren't too used to exercise, it certainly gives them a little bit of confidence. It's simple to do, they know how to manage it, and it's easy to get going with it. It's something I just thought we should maybe touch on. We've talked about the idea of getting them up and getting them going, and the next thing is ideally getting them, getting them discharged and getting them out. There's always tends to be, I know from a family perspective with the patients, and perhaps even from a local GP perspective, there can be that little concern and worry that, why are they getting out that early? What are the benefits of it? And what could go wrong, or what if something goes wrong? So could you maybe just, maybe Gavin, you might just enlighten us on the idea of that earlier discharge and what are the benefits for the patient?
Yeah, well, the benefits for the patient, again, goes back to the fact that they never feel sick. So as soon as people get back into their own environment, in their own clothes, they're not sitting in pajamas and, sort of being fed their breakfast or whatever, they're having to get up themselves and get it. All just leads, it's all just part of that culture that they're not sick, that they're just recovering from their operation. And the end of net effect of that there is that by and I think a good landmark is sort of 6 weeks afterwards, is that a lot of time they may not be completely normal 6 weeks after the surgery, but they're getting pretty close to it. And that 6 weeks, a few years ago, would have been much more like 6 months, you know. So that's the huge advantage. And in terms of now, again, things do still take time, and you know, we can be really guilty here of shooting ourselves in the foot by telling people that, you know, by 6 weeks they're going to be absolutely perfect. They're not, but they're much more likely to be by actually, you know, partaking in this whole process.
Yeah. Excellent. Mihai, you've kind of similar thinking regarding the early discharge. I know you're a big advocate for it, and we've had a couple of your own patients recently, your medial unicondylates, that have been discharged on day one. I seen one a few weeks ago, and he couldn't get over how brilliant it was to be lying in his own bed that night, which was a really, he found it really impactful and felt that he was already on his way to recovery and really taking ownership of his own recovery, which I think from my point of view is so important, that those patients are really leading the way in their own recovery. Is that one of the reasons you might, again, pop them, or I advise them to be discharged home, or what are your thoughts on it?
I guess, like everything else, is selection, you know, and some patients really want that, and they're exceptional patients, really, you know, and maybe it's about identifying those suitable patients who will say, look, I want to go home. And then I only have had 2 patients that we trial this to see, in terms of the system, how are we confident enough that the patient was done at 7 o'clock in the morning and went home that evening at 7 after a partial knee replacement, but was never pushed. That's the point. I mean, and I stress that to everybody, that nobody leaves until is ready to leave. We had another patient, and I guess you talk to them in the surgical, in the preoperative meeting, and you see, look, this is the option. And some people do want to go home, and you know, because we follow them with phone calls, because you want to make sure that they don't go home and they're in pain, you know, and they seem to be doing okay. But a lot of surgeons get caught up into time of discharge. I don't think time of discharge matters that much. I think it matters comfort at discharge and confidence. And that doesn't necessarily come from the surgeon. It comes from the whole team. It comes from the nurses, the physios, you know, to make sure that their journey is smooth and everybody is, you know, trying to reassure them and build up their confidence, because the worst thing would be to send someone home and then have him coming back, and even for small things, you know, sometimes there would be a little ooze from the wound and they don't know what to do with it. They wouldn't have the resources. So we have to cover all that ground to make sure that, first of all, we are confident, and secondly, they are confident to go home.
Brilliant. You're just touching there on, which was just another little thing I wanted to touch base on, just because it can be relative to the GPs here. With regards wound management and dressing, we've adopted some different types of dressings, and thankfully, as Gavin has already suggested, things are evolving over time. But I know you both use Dermabond quite a bit now. Could you maybe, Gavin, speak a little bit more about that and the use of it, and, you know, even regarding wound management when the patient goes back? Often they don't need to see their GP to do it. They can usually remove it themselves.
Yeah, so I mean, I think, again, I'll be similar in that, Voga. We tend to put in all our sutures dissolvable and subcuticular, so which means they're all in under the skin and there's nothing to get removed. You know, you're not having that sort of, which again, patients alone don't like, having to get the clips or even stitches taken out a couple of weeks later and having to go back for a follow-up visit for that. But combined with that, yeah, so on the hips, I'll use a dress called a Dermabond Prineo dressing, which is just basically, it's like a clear dressing that goes on over the top. So the advantage is you can see the wound and any problems with it. You really, it is really the ultimate in sort of low maintenance, and it doesn't need anything. It doesn't need changed. It can stay on. The patient can shower away, and literally then at 2 to 3 weeks afterwards, it'll start to fall off themselves, and they can just tear it off themselves at that stage. You know, so I think that's You know, it's been great for the hips. For the knees, I don't use it because of the bending and straightening. It's just that a little bit harder to get a very definite seal on that. So I haven't. But again, the whole. I remember, you know, years ago we used to have like a ward round in the morning where all the dressings were changed every day, and they were all the wounds were thoroughly cleaned, and we had lots of problems with wounds. Now the dressings are changed when the patient is about to go home, and that's it, and they can stay on for another week to 10 days. They don't have to be changed at all. Even if they get dirty, it doesn't cause problems as long as they're sealed in, you know. So yeah, that's been another big change over the last number of years for us.
I definitely find, from my point of view, patients coming in, when I see them in those early weeks post-surgery, they all comment on how it's so much easier to move when they don't have those external stitches and staples, and they're a little more confident because they can really see their wound, which is, in particular with those hips, they're that little bit more confident in it, which is great. I guess just one of the last things I wanted to touch base on was, over the last couple of years, 2 years I think for yourself, Mihai, and over the last year, Gavin, you've adopted to your patients both hip and knee replacements, patient dependent, and provided they're fit. You moved them between 2 and 4 weeks onto using walking poles instead of elbow crutches. I know, Mihai, you kind of started this off, so we might revert this one over to you, but can you just elaborate a little bit more on that and really the benefits of it for the patients, or why it came about?
Well, I first was aware of the use of walking poles in recovery when I was in Canada in fellowship, and they were using it there. They were starting to explore the opportunity to use walking poles. But sure, in Canada, everybody uses walking poles. They all sort of go around in the mountains, and they all, as a fitness regime and as an exercise routine. So then I sort of followed that up from a distance, and I noticed that they got into spinal surgery and rehabilitation with hips and knees. And we, myself and yourself, trying to bring them over to Ireland, and we managed to get them into the clinic and use them routinely for our hips and knee replacement. And the walking poles that we use, they're very smartly designed. They have a small little ulnar gutter that actually give them a little bit of weight bearing as well. And the idea is that with crutches, after 2 or 3 weeks, both after hips and knee replacement, they become a little bit of a hinder because they're elbow crutches and the patients are stooped forward a little bit, particularly if they're getting better and they want to sort of engage with their longer stride and stuff. So the walking poles have a different concepts. They sort of elevate the chest and the shoulder. They straighten up the spine, and they give you a bit of a core workout as well in the upper limb. And because you use them they develop a smoother gait. So they eliminate that, I guess, that residual limp that patients would have from having had surgery on that limb. So we found them quite useful to date. You see those patients, Blauhin, when you instruct them how to use them, and we see them when they come back at 3 months' time. So we do get quite good feedback. Some people just don't want them, and that's fine.
Yeah, I think, no, absolutely. I think the idea of people feel they're a little bit taller with them, and they're elongating their gait a little bit more when they're trying to rehabilitate post-surgery. So I think they really were the main things, that kind of one of the main things that we just didn't touch on again, Mihai, which related to you, was just over the last year or two, you've engaged with your patients using an app to help guide them through the surgical process too. How have you found the patients? So I will touch base on it just for the presentation after, but it's really just to inform patients, or what have you found patients have taken from using the app post-surgery or pre-surgery?
I think together we worked on developing this app, and the idea is that I saw this app in Netherlands called Patient Journeys app, and essentially it gives the right information at the right time. So it's an app that the patient download on their phone, and they get a message with a picture or a video, and it's all referenced to their surgical date. So if you have your surgery next week, you get a message each day through the app saying, do this, don't forget to wash your area with chlorhexidine. And immediately after surgery, little encouragements, don't forget to do your cycling, get up. Don't worry if there is any bruising coming on. This is normal. And essentially, because traditionally we used to give them a book, which we still do, but a lot of them don't read it and they get information overload. So the app really streamlines the messages, but it also gives them an opportunity to engage back with the clinic. They have our email address, they have our phone numbers, and talking to some of my colleagues, they were worried that their office would get inundated with calls and stuff, but it didn't. And we know because we're looking after these patients, and you are. So it's a very interesting concept. The more available you make yourself in terms through this technology, the less engagement, because they're reassured, essentially. And I'm sure, Gavin, you have used the app as well in your patients. I'm sure that there's a similar feedback.
Yeah, I mean, absolutely, yeah.
I think, Mihai, probably what you said there, the word reassurance is probably a good one to finish on here regarding, I think it's one of the most important things for encouraging an enhanced recovery and that self-directed care. Obviously, there's so much more to it from a surgical point of view and a medical point of view, but I think reassurance is one of the most important things that patients get pre-operatively and post-operatively to help encourage and motivate them for that enhanced recovery. Similar to what Mihai has already been speaking about, I just wanted to show you a little bit more information about our app Succeed, which we have designed for our patients here in Santry. Succeed basically gives our patients the right information at the right time. It informs patients of what they need to know and when they need to know it. For example, our knee replacements need to know that it's normal that they get lots of swelling. It's normal that they might have a little bit of bruising and swelling down their leg. Our hip replacements need to know some of the do's and don'ts in those first couple of weeks initially. And sometimes those messages can get forgotten, or just the patients sometimes might find when they're in hospital here that they tend to get a little bit confused or forget some of the things we've said to them. So we know that a better informed patient leads to a better surgical outcome. So again, this enhances our recovery process and it works towards our enhanced recovery or optimal level of care. This ensures that they've got information at their fingertips, so the patients just get their messages informing them of what they need to know on those particular days. It also allows us to collect patient-related outcome measures. These basically allow us to ensure that the surgical procedures and the rehabilitation we're doing are having the efficient outcomes and good outcomes that we require post-surgery. And what we did find from some of our research before creating the app, that lots of patients said they were more likely to respond to an app that they already trust on their phone. So the idea is that our app is giving them that helping hand throughout their surgical journey, which means they're more likely to give us that response regarding some of the outcome measures. I also just want to show you a little bit, just to mention what Mihai and Gavin had already mentioned regarding the walking pose. This is a relatively new concept that we've been using over the last 18 months to 2 years. And really what we do between weeks 2 and 4 post hip and knee replacement, both total and partial knee replacements, we try and move our patients from walking crutches onto walking poles, provided they're able to do so and we feel they're fit to do so. This just allows and facilitates for a much more natural and efficient walking pattern to try and normalise the patient's gait a little bit quicker. It also gives them that little bit more independence. So I just have a small little video here, again, just to show you that idea of enhanced recovery, the basis as to why we mobilise our patients early and then why we try and move them onto walking poles. This lady was kind enough to send us in through some videos. So this first video just shows her at day 5 post bilateral medial unicondylar replacement. You can see as she's coming up the hole, already she's taken the bigger dressing off her left knee. We've left it on her right knee as it was weeping a little bit, but she's moving really well. She's mobilising comfortably with her 2 crutches. Then at 2.5 weeks post-surgery, she had been moved on to her walking poles. She's slowly getting used to them, but you can see already she's standing up nice and tall and engaging into a normal walking pattern. We've found really, really super results with our patients using our walking poles and great feedback from them so far. They help them recover that little bit quicker and regain their independence a little bit sooner with their walking. It's probably a a good note to finish on, I think, this evening. So thanks so much, Gavin and Mihai, for your time and for discussing it all through with us this evening. And we'll just take any questions then when everyone's ready.